Good evening, everyone, to today's evening session of the case present. Good evening, everyone, to today's evening session of the case presentation. The first case will be a gastrointestinal system case. The presentee will be Dr. Sudarshana, a third-year resident at the Department of General Medicine, AMRITA Institute of Medical Sciences. And the examiner will be Dr. Velayudhan sir, who is a professor at the Department of General Medicine. He's completed his MBBS from Government Medical College, Calicut, and his MD from Government Medical College, Trivandrum. He's a skilled clinician and academician par excellence. We welcome you, sir.
Good evening, sir. I'm going to present the PG case discussion on the GIT system. My patient is Mr. Rajan, 46-year-old male from Malappuram. His occupation is shopkeeping. He presented to the hospital with complaints of fever for the 2 months duration and multiple neck swelling for 1 month duration, associated with nausea and vomiting for 2 weeks duration. History of presenting illness. Patient was apparently normal 2 months back. Patient developed high-grade fever, which was intermittent, associated with chills and rigor. And he also gives complaints of evening rise of temperature and night sweats, which was relieved with antipyretics and tepid sponging. And fever was present mostly on all the days, and he was feeling feverish throughout the day. Patient noticed swelling in the neck region in the both sides of the neck, which was initially small in size, and it increased in the size to attain the current size. And he gives no history of any associated pain or ulcer formation, and there is no history of any sudden increase in the size of the swellings. And he also gives no history of any difficulty in moving the necks. And he also gives complaints of nausea and vomiting, which is 2 to 3 episodes per day, non-projectile, not blood or bile stain, and vomitus contains food particles, and vomiting is present immediately after food intake, and it was not associated with heartburns or dysphagia. There was no history of any abdomen pain, distension, or altered bowel habits. No history of pedal edema, facial puffiness, oliguria. No history of any blood in stools. No history of jaundice, itching, or high-colored urine. No history of cough, dyspnea, chest pain, and no history of any burning micturition or dysuria. He gives a history of loss of appetite in the past 2 months, associated with loss of weight of around 6 to 7 kgs in the past 2 months. No history of hematemesis or melena. No history of joint pain, swelling of the joints, or early morning stiffness or rashes. No history of any travel to outside the state. Past history. No history of any similar illness or prolonged fever in the past. No history of tuberculosis, and there is no history of any contact with patients with tuberculosis, and no history of type 2 diabetes mellitus, systemic hypertension, or ischemic heart disease. And family history. His father is a hypertensive and diabetic. Mother is a hypertensive. There is no family history of any prolonged fever or malignancy. Personal history. His occupation is shopkeeping, and he's a chronic smoker, and he smokes 1 pack per day, which is around 25 pack years, and no history of ethanol intake, and normal sleep, reduced appetite is there, and there is no pets in his home. Summary. My patient is Mr. Rajan, 46-year-old male, presented with complaints of fever for 2 months, multiple neck swelling for 1 month, associated with nausea and vomiting for 2 weeks, and associated with loss of weight and loss of appetite, with history of chronic smoking. I would like to consider
what are the possibilities you will consider in this patient, in your patient?
I would like to consider first my DD is tuberculosis.
Then
next one is lymphoma.
Why do you consider tuberculosis as a first differential diagnosis in this patient?
Since tuberculosis is most common in our country, and it is a treatable condition, so I would like to consider tuberculosis as the first differential diagnosis.
Okay, then.
And
then
next is lymphoma, sir. Since patient presented with complaints of fever and associated with multiple neck swellings, I would like to consider lymphoma in this patient also.
Any other differential diagnosis, since there is a prolonged fever with weight loss?
I would like to consider infective endocarditis.
But is the patient is having any cardiac symptoms?
No, sir. No complaints of chest pain, no dyspnea on exertion, no cough. And
Since he is a chronic smoker,
yes, sir.
do you entertain malignancies in this patient?
Yes, sir. That can be a possibility of malignancy with secondary lymph node deposits.
Any other infective disorders that can prolong, that can present with prolonged fever?
Brucellosis and typhoid and melioidosis.
What are the possibilities here in this patient?
In this patient, there was no history of any pets in his home, and no history of any drinking of unpasteurized milk. So brucellosis can be ruled out, sir.
Then melioidosis?
Melioidosis, he is having prolonged fever with lymphadenopathy.
Neck swelling, you think it is lymph node enlargement?
Neck swelling can be a lymph node enlargement, sir. I need to examine the patient.
Okay, so you consider tuberculosis, malignancy, then infective disorders like enteric fever, brucella. Okay.
Yes, sir.
Okay. Any connective disorder, tissue disorders you consider?
Kikuchi's.
Any immunoglobulin deficiencies you consider?
Yes, sir. IgG4 deficiency
Can present as
present with a prolonged fever and neck swelling, sir.
Okay, go ahead. What are your findings?
On examination, patient was conscious, cooperative, obeying commands, and his height was 154 centimeter and weight was 56 kgs, and vitals, pulse rate 84 per minute, regular, normal volume and character, no radial delay, no radiofemoral delay, all peripheral pulse were felt equally, and blood pressure was 110 bar systolic and 70 millimeter of mercury diastolic in the left arm in the sitting position. Respiratory rate was 18 per minute, abdominal thoracic regular, saturation was 99% in room air, temperature was 99 Fahrenheit. On a general examination, pallor was present, no icterus, cyanosis, clubbing, or pedal edema, no features of infective, features suggestive of infective endocarditis, such as no Janvey lesions, no petechiae purpura, no Osler's nodes were present, and cervical lymph node, there was a palpable swelling of size 2 × 3 centimeters in the level 2 left side, which was firm in consistency, not tender, no warm, mobile, not attached to any underlying structures, and another lymph node palpable in the level 3 right side, which was 3 × 3 centimeter in size, and that was firm in consistency, and no warmth was or tenderness, and it was mobile. Another lymph node of size 2 × 2 centimeter in the right level 2 lymph node, which was firm in consistency, not tender, no warmth, and it was mobile. And no palpable axillary, submental, or submandibular lymph nodes. Systemic examinations. Oral cavity examination, lips normal, teeth, gum, tongue, buccal mucosa, palate were normal. Inspection of the abdomen, shape of the abdomen, it was distended. No flank fullness, umbilicus was normal. Movement of the abdomen with respiration is equal in all quadrants. No visible peristalsis or mass was present. No dilated veins. Hernial orifices were free. Palpation, superficial palpation, there was no warmth or tenderness. Deep palpation, liver was palpable 10 centimeters below the right hypochondrium, and it was firm in consistency, non-pulsatile, and surface of the liver was smooth and with sharp margins. Spleen was palpable 4 centimeter below the left costal margin towards the umbilicus, and it was firm in consistency. A splenic notch was palpable in the infralateral border, and it moves with respiration. Percussion, liver span was 16 centimeters. No shifting dullness was present. Drop space dullness was present. Auscultation, bowel sounds were normal. No bruit or venous hum. No hepatic bruit or splenic bruit or rubs present. Rectal examination, no fissure or tenderness, no ulcer or mass palpable, and a fecal stain was present. A spine was normal. Other system examination, cardiovascular system, heart sounds were present, no murmurs or no additional sounds heard. Respiratory system examination, trachea, there was no deviation of the trachea, no features of Harnow syndrome was present, and bilateral air entry was present, normal vesicular breath sounds, no added sounds. CNS, patient was conscious, oriented, higher mental functions were normal, no flapping tremors, cranial nerves, motor system, sensory system were normal, cerebellar functions were normal, gait was also normal.
So what are the salient points, findings in these patients?
Patient presented with complaints of fever for 2 months duration, associated with multiple neck swelling for 1 month duration, associated with nausea and vomiting, with loss of appetite, loss of weight, and he gives a history of chronic smoking. On examination, patient had pallor and cervical lymphadenopathy and hepatosplenomegaly.
So after the examination, what are your possibilities?
I would like to consider tuberculosis as my first differential diagnosis.
Points in favor?
Points in favor include patient gives history of prolonged fever with lymphadenopathy and hepatosplenomegaly and weight loss.
Okay. Other differential diagnosis?
Lymphomas, since patient presented with fever and multiple lymphadenopathy and hepatosplenomegaly and weight loss.
Then?
And I would also like to consider malignancy, since he gives history of chronic smoking and associated with weight loss. I would like to consider malignancy with secondaries in this patient.
Malignancy, what type of malignancy? Why the neck swelling?
It could be lung carcinoma of the lung, or there could be secondary deposits, lymphadenopathy.
Okay. Liver, 10 centimeters liver.
Yes, sir.
Is it a common finding?
No, sir.
Then what can it be?
That could be secondaries in the liver, metastatic.
So initially your line of thinking was whether it is brucellosis or
Yes, sir.
enteric fever.
Yes, sir. Yes, sir.
Now you don't consider.
Brucellosis, a patient gives history of a long-term prolonged fever with hepatosplenomegaly, and I would like to send IgM brucella to rule out brucellosis.
Okay. So what about enteric fever?
Enteric fever, there was no history of diarrhea and no abdomen pain, and the fever was it was intermittent fever with no stepladder pattern.
How do you differentiate the fever in enteric fever and the malarial fever?
enteric fever, there will be persistent hike in the fever like step ladder pattern. In malaria, there will be an intermittent fever-free period, symptom-free period. Patient will have fever followed by sweating, followed by prodromal symptoms such as lethargy, fatigue, followed by fever-free, symptom-free period, anictic period.
How will you diagnose that?
Malaria can be diagnosed with peripheral smears, thick and thin blood smear, and typhoid, we have to send blood cultures and salmonella antibody.
So what is your plan for this, our patients?
Our patient, we can do CBC, basic investigation such as CBC, CRP, chest x-ray to rule out any infections, or chest x-ray to look for any parenchymal disease, to look for nodules, rib erosions, or any fluid hilar lymphadenopathy, and ECG 2D echo to look for any vegetations, and peripheral smear to look for parasites and the counts, and I will do a manto, USG ultrasound abdomen for this patient, and lymph node biopsies.
Is there any planning for CT scan abdomen, or if the lymph node is not showing any positive finding for our diagnosis, do you proceed with any other investigation?
CT abdomen with liver biopsy if the lymph node biopsy is and if there is no diagnosis.
So you mean to say our case is likely to be a case of either lymphoma or tuberculosis?
Yes, sir. Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you, sir, and Sudarshana for that case discussion. Sir, we actually have some questions in the chat which have come. Someone has asked this whether HIV is a possibility in this case. I think Dr. Sudarshana, can you answer that?
HIV can be considered in this patient, sir, because a patient gives history of prolonged fever with lymphadenopathy is present. So HIV can be considered in this patient, sir.
Okay. Because there's prolonged fever with generalized lymphadenopathy, no?
Yes, sir.
Okay. And when someone has asked, like, how can you differentiate kidney enlargement from a massive splenomegaly clinically? Like, can you differentiate? What are the points?
Spleen is location of the spleen is in the left hypochondrium. Kidney is located in the lumbar region, and enlargement of the spleen will be towards the midline, whereas enlargement of the kidney will be towards the left iliac fossa or the left hypochondrium. And spleen moves with respiration, whereas kidney will not move with respiration. And insertion of the fingers between the costal margin and the organ will be possible with kidney, whereas it is impossible with spleens.
What about this notch? Can notch help you differentiate?
Yes, splenic notch will be palpable in splenic enlargement, whereas no notch can be palpable in kidney enlargement.
And someone has asked, how do you do a bimanual palpation?
A bimanual palpation for kidney, we have to keep the palm of the right hand. For palpating the left kidney, we have to keep the palm of the right hand in the right lumbar region and the left hand in the left loin, and we have to give a pressure upwards and from the left hand, and we have to give a pressure downwards and inwards with the right hand, and we have to look for the organs.
Okay. There was one more question. So someone asked about the causes of tender hepatomegaly.
Tender hepatomegaly can be seen in acute hepatitis, abscess, and in case of acute Buchiari syndrome, we can have tender hepatomegaly, sir, and congestive heart failure.
Yes.
And so I think one part of somebody's highlighted in the chat that I think in this case, genitalia examination was important. I think was it mentioned? I didn't. I think you forgot to mention that
Yes.
genitalia, because we are suspecting sometimes malignancy with metastasis, no? So I think that's a very valid point which was raised. Like it's very important to examine, especially in GIT cases. Lesser that well answer. Sir, you're muted, sir. Sir, you're muted, sir.
It is necessary. Can you hear me?
Yes, sir. We can hear you.
Okay. Examination of just external genitalia is very important.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Yes, so we have to look for this like testicular tumors, especially if this unexplained fever. And
Definitely.
yeah, there has been cases like when this testicular swellings have been missed and extensively worked up cases, but just a
I fully agree.
clinical examination, the testis revealed a large mass actually in the test, and the candidate, the boy, was actually shy to reveal the testicular malignancy because he was young and he didn't want many people to examine. There have been cases like that, and finally it became a testicular cancer actually, the final diagnosis. And someone has asked
You are
also,
absolutely right, Dr. Subhash.
sir, and someone has asked about sarcoidosis as a differential diagnosis. Sarcoidosis in this case,
In a prolonged, Sudarshana,
Yes, sir.
can you answer?
Yes, sir. A patient presented with history of prolonged fever and lymphadenopathy. So we can consider sarcoidosis, but hepatosplenomegaly is very rare in sarcoidosis. So.
one more question.
So many differential diagnoses we have to consider. When there is a prolonged fever, only we have taken into account only a few conditions.
Yes, sir.
Right, Dr. Subhash?
Yes, sir. So someone has asked about sarcoidosis as a differential diagnosis. In this
Definitely, you can consider, but some major ones with respect to our circumstances.
Yes, sir.
She considered tuberculosis one on the foremost one because it is one of the treatable condition, common condition compared to even lymphoma.
Yes, sir.
Right.
One more question that was asked was, how can we pick up mediastinal lymphadenopathy clinically?
Sudarshana.
So mediastinal lymphadenopathy, clinically we can pick up no.
You are right. Clinically, it is very difficult because we have to look for the mediastinal widening and it is deep. So as Sudarshana said, it is difficult to detect clinically, but along with that, there will be some other findings. Dr. Subhash. Hello.
They are answering percussion in second space, sir. Some students have answered. Yes, sir. We can. It might show an impaired or dull nose.
Second space.
Yeah.
There are so many other conditions we have to think of.
Yes, sir. Other structures also. Yes.
Percussion wise alone, clinically very difficult. Yes,
sir. And someone has asked about perrectal examination, whether it was done in this case. Perrectal.
Definitely, she has.
Okay. And what was the finding?
It was normal, sir. No ulcer, no mass palpable.
Okay, there was no mass palpable. Yeah, so that's also very important thing in GIT examination PG level. We have to look for the perrectal and mention it also, specifically in the case sheet, whether there is any hard prostrate mass. Very, very important, especially in this case.
Important.
Yes,
true. Sir. Absolutely, I agree.
So someone has asked, done it. Yes, sir. And so someone has asked also last about what is the cause of matting in tuberculosis.
Sudarshana.
Yeah,
matting is very common finding in tuberculosis because of the periodontitis, and unlike in lymphoma, which is rubbery,
separated, whereas in tuberculosis, matting because of the periadenitis and fibrosis, you know, the capsule, addition of the capsule, so matting is common. So many lymph nodes will be there, so there will be matting and adhesion.
Okay, sir.
In cervical, axilla, wherever it is enlarged, there will be matting, not a single one. So there will be, number will be more, and so also there will be matting. And because of this capsule group together and attached, there will be matting.
Okay, okay, sir.
Okay, sir. So I think we are getting into time for the next session. Thank you for this wonderful session, sir, Dr. Sudarshana and Velayudhan, sir. We'll now move on to the rheumatology session with Dr. Midun, sir, and Dr. Namita. Thank you.
Okay.
Thank you, sir. Thank you, sir. Thank you very much. Sir.
Thank you.